Ladies and gentlemen, and all of you EMTs and young and old, I see some of you are younger even than 8 tonight. I'm not going to speak at all of hospital care. I hope this is what you're prepared for. But what I am going to do in the very beginning is discuss with you some of the basic fundamentals, once again, of hypothermia and immersion injury, cold injury in the form of frostbite and other forms of cold. And then we will spend the last 45 minutes discussing the various problems that you might present. And during the lecture, I hope we can cover some of the problems that may bother you all the way from being a first responder with nothing except yourself, and perhaps you're the victim, versus being a EMT type 3 responder with all the sophistication that you have in your wagon and what you might do about it. Right. Have the slides, please. See, am I in your way if I stand here? Well, I put this slide up here because I didn't know how serious some of you were. And for those of you who want to be entertained, we'll try to do that. If you want to seek a little knowledge, what little knowledge we have, we'll try to do some of that too. You know, some of you may have had occasion to treat severe freezing injury or freezing injury that wasn't so severe and hypothermia. And if you've been in the business very long, you'll recognize that there have been many changes. And what we say today basically may be altered somewhat in the future, although I think we pretty much have the groundwork done at the present time. Now, I'll try to be brief so we can get to your problems, and you can see this is about as brief as you can get and still stay happy. That's in case you weren't interested and weren't thinking that was the doctor presenting the lady with the bill. So, if you learn nothing else in regard to the treatment of hypothermia, just learn this much. What you do is think heat. No matter how else you treat the patient who's presented to you or that person that you find, you want to make sure that even if you don't or can't provide heat or much heat or hardly any heat, you want to prevent further loss of heat so that they don't drop down into a severe state of hypothermia, say less than 70 degrees, where resuscitation is most difficult. We have a pretty fair record around the state of Alaska, and this much I can tell you, regardless of the method of treatment, providing something wasn't done that was a mishappenstance or something happened in transit, or perhaps we didn't have the proper drugs on hand for the proper diagnosis that eventually was made. We hardly ever have a death. We have never had a death at this hospital, and I don't think I have in the series we have, which is almost 100 now, where the core temperature was under 80. That's something to think about if you are able to measure the core temperature. From about 80 to 75 in Fahrenheit, then it gets a little bit more difficult, but even then the record is good. And it's down below 75, 73, and 72 degrees, down to 65 degrees, that we have considerable difficulty resuscitating a patient. And we'll get into that a little bit later. So you think heat. If you can't provide it, try not to lose it. The reason we're interested in this, and this is a picture of 1712, the Swedish army had gone into Norway. They were turned back by the Norwegians and by a severe blizzard. They lost 3,000 men, and that's when we learned a great deal, learned something of cold injury in time of stress, in time of war, time of famine, and something all of you should give consideration to in this state at the present time, because we've had a lot of more recent activity, more than most of us like. But all you'd need to do to have more than a case of hypothermia or 1 or 2 frostbite patients, to have a nice earthquake somewhere between the 15th of December and perhaps the 1st of March, with the temperatures down in this area around 20 below or more, people homeless, without shelter, food perhaps without water, certainly without adequate clothing, and then we'd be treating cold and exposure patients by the hundreds and not just by the occasional one. And it's something for you to give some consideration to because such a thing could happen. And in history, this has happened. The Italian army in 1942 went into the Balkans and went into Greece, and they lost 60,000 troops to the cold. That was World War II. You don't have to go back Napoleon's debacle in 1812 and 1813 to lose 80 or 90,000 men, but you can still do it at the present time. The Israelis had 3,000 cases of frostbite and hypothermia in the Golan Heights just about 7 or 8 years ago, and a little bit after that in the fighting up in Tibet when the Indians and the Chinese got to it, there were 30,000 cold casualties, most of which you don't know about. And this went on until in the Falklands, when you'd think the British, of all people, with some American help and all their advisors, would know perhaps how to handle cold, they went down and had an unspecified number of cases of cold injury, hypothermia when the ships were sunk in the cold South Atlantics, associated and complicated by severe burn at the same time, as well as not so much a frostbite, but an immersion injury. And the number of cases the British had was multiplied 3 or 4 times over by the cases the Argentinians had. So this is always with us, and the worst of all of this was that these people, knowing all that there is to do or should be done about cold, didn't have the proper clothing, they didn't have the proper footgear, they didn't have an opportunity to stop. To win was overall, they didn't take time to sleep, to rest, to melt snow or ice and make water, so they were dehydrated and hypovolemic and had a great many other problems. And sometimes when you think of all the exigencies of war and stress and other problems that arise in this earth, I'm not so sure that we'll ever be able to do any more than just approach the problem as it's brought to you when you find it, or at the emergency room when we are called to see it, or if we're out in the field with you. Well, you can give some thought to all of that. Hypothermia is not old. If you are biblical in origin and you read 1 Kings, you'll find that King David was an elderly man, had hypothermia. They tried to warm him in the time-honored way at that time and very unsuccessful. So you read about what's new in the United States and England, hypothermia, the elderly in the last 5 or 10 years. It's not really so new as you think. Now, what do we know about injury from cold? I have a little problem here with some glasses. Can you tell me if that's in focus? Or there's a focusing button on there if someone wants to ever change it. Well, hypothermia for our purpose is general body cooling. The core temperature falls below 94 degrees, and we have failure then to maintain that steady metabolic state and rapidly drop off into lower temperatures. We've chosen 94 for a lot of reasons. Actually, physiologically, if you're 95 degrees or less, presumably you have hypothermia. Now, I've done some work at the Pioneers Home here in Anchorage, and I can tell you that people who are well-clothed, well-fed, and quite healthy for their age have core temperatures somewhere between 96 and 94, 95. And so we know that as you grow a little bit older and your metabolic state steadies down to a very slow rate or almost a crawl, that your core temperature drops just a little bit. So I'm not so sure that we should say they're hypothermic just because they're 95 when they do well and they're healthy and they can get around. I think also the definition of hypothermia is 94 is because most temperatures, most thermometers read 94 degrees. And most of the patients we've had referred to us when they tell us they have a patient who's comatose, who is not responsive, who is diaphoretic, who is unable to respond, no longer shivering, and you say, what is their temperature? I wonder if they have hypothermia. They say 94. So we know then it's probably anywhere between 90 degrees and possibly 80 degrees Fahrenheit. So it's nice if you haven't anything else in your vehicle, spend $2 or $3 or $4 or $5 or whatever the cost of that is now and buy yourself a low-reading thermometer. If you have one that's a Yellow Springs instrument or something that requires, it's a digital readout and requires a battery, make sure you have extra batteries, because the next common problem in determining the adequate temperature is that we have battery failure for much of these machines that we're dependent upon. The etiology, the cause of accidental hypothermia, you know, is poor physical condition, dehydration and starvation, and particularly dehydration. Lack of water, need for water is the commonest cause of problem in the mountain, in the wilderness, and in every situation where you're exposed for any length of time to cold, except perhaps in sudden immersion if your fishing vessel sinks. But if you're in a fishing vessel and it sinks and you happen to get yourself into one of these new survival suits, and we've had patients who survive 5 to 6 days in those suits, and I think they're really fabulous, is that something else happens there. You're a little bit cold, you usually don't have water to drink, and by the process of cold diuresis or urination, you fill that suit up with urine, and you lose a lot of water that can't be replaced, and then you develop, besides the hypothermia and other changes. A very severe immersion injury secondary to ammonia burns from the concentrated urine that eventually settles in your socks and in your boots. This is the old drawing that you've seen many times, the way you lose the heat, which you should understand by evaporation or conduction against a cold object, laying the snow against a tree trunk, by convection due to wind, and the greater the force of the wind, of course, the more likely you are to have increased loss of heat as it's blown away through the skin surface if you don't have the proper covering. And then again by conduction, which is, and respiration also very important. And I mention this because this is important to you in the care and the treatment of the patient who has accidental hypothermia or frostbite. Just about close to 25% or more of all the patients we see, perhaps 50% of all the patients we see outside of the city areas and from a outlying area coming into the Anchorage area, or perhaps coming into Talkeetna or Girdwood from some other area, is carried by helicopter. And a large number of the patients who already are cold and have very low temperatures or have freezing injury, when they're put in the helicopter, generally speaking, it's in a cold area, and particularly if it's a mountain rescue, in most cases the pilot doesn't want to shut down the rotors. And as a result of this, they have forces of wind that may be up to wind chill factor dropping you down to minus 50, minus 60 degrees Fahrenheit. Perhaps the wind forces or whatever a helicopter generates, 70, 80, 90 knots, depending on how rapidly those rotors are going. And the result, too, is that in many cases you can't get the stretcher, get the patient in a certain helicopter, so you take off the door. And 30 seconds up to 3 or 4 or 5 minutes go by. So we've had a fair number of patients brought to us who have had hypothermia, severe from hypothermia, moderate, just from the transfer from the area where they were picked up into the vehicle itself. And I'll give you a good example of that. We had someone who went down the inlet here, 180 with 2 men, and they were all in Eddie Bauer equipment. They all weighed over 200 pounds, these 2 fellows. They're great big husky men. And one of them, the chopper landed with his pontoons and got one man on the pontoons into the aircraft and went down to get the other, and he fell and slipped. He fell in himself, and he was pretty cold. So he took the other patient and tied him over the float, and then he got into the aircraft, and he was so cold he could hardly operate the aircraft, but he managed to bring it into the beach, and that took about 25 to 30 minutes. When he got there and came to the hospital, a man who originally had been in the water, and both of them had been in 45 minutes, had a core temperature, the one person who was able to give us some history, and had a core temperature of about 87 degrees, and the other's core temperature was 75. And that was just not only from being cold, but being on the pontoon with the rotors going all this time. So the other rule of thumb is if you're going to rescue them, try not to make them worse in the process of picking them up. We'll get into that a little bit further. Well, there are lots of things you know when you're out in the cold, and stress is one. Some people don't like this cold environment. Besides all the problems of hypothermia and frostbite and loss of heat you have for people who've been in the cold for any length of time and don't want to be there, for men who climb the mountains, and eventually, as they've been up on the mountain or on the glacier or some other area for 10 or 12 days, they get sick and tired of melting a gallon of water to get a gallon of snow to get a pint of water. And the next thing you know, at the same time, if it's cold and the wind blows, they don't like to get out in the cold. They don't like to urinate. They certainly don't like to bear their derriere and do the things that they're supposed to do. And they're not aware of the fact that if you do cut a slit trench and you have to defecate in the cold, and it's 30 or 40 or 50 below and the wind blows, you have a little bit of chill at first, and then there's about 30 seconds to a minute and a half where you can do what you have to do, and you have a flush, which is compensatory, and that's nice, and you don't mind doing those things. If you don't know all of that, then you don't do the things you're supposed to do. You suppress all your natural functions, and the result then is very severe hemorrhoids and fissure in ano and lots of other interesting little things that happen. And we see these people that come in the emergency room, and some of those are the complications we see besides all the problems of hypothermia. Well, what happens then when you start losing heat? You have a core temperature perhaps of 100 or 99. Most people who don't smoke have a skin temperature of 90 to 93 degrees Fahrenheit. If you smoke Camels and Lucky Strikes, your skin temperature is probably about 85 degrees, and it gets worse if you have other little labile vasomotor problems underneath that, including burgers and diabetes and just plain cold feet that many people have. Now, when you have exposure to cold, then to protect the core, you have a vasoconstriction of the skin and the small vessels in the skin, and the skin temperature may drop then to 85 degrees, 80 degrees, 70 to 75 degrees, and there's a transfer of blood and fluids into the core itself. Now, if this loss continues for some reason, you're unable to protect yourself, if you don't have enough hair or layered clothing to maintain heat, and you can persistently lose heat, then the vasoconstriction goes on and continues to an extent where the core, still attempted to be protected, is still around 99 degrees, but the periphery may drop from 75 to 50 down to 45, and when the peripheral temperature of the skin, of the extremities, the face, the foot, whatever area we're discussing, drops down to 26 degrees Fahrenheit, tissue will freeze. It doesn't make any difference what race you are. You hear a lot that southern Negroes freeze first, and then northern Negroes, southern white, and the northern white, and then the Eskimo and the Indian, they freeze last because they are acclimatized, and the Alaskans that never freeze at all because they drink so much. Well, that isn't quite so. What really happens is that you have, in many cases, such acclimatization that those who come to this country from the south, when it gets real cold, and you may have some friends who are like that, well, right away when it's cold they want in, they know it hurts, and they're not going to put up with the foolishness of freezing something because you may not know it's cold, but they know it's cold right now, and someone else is going right along with them, and they're acclimatized, and they have less warning, and they're not complaining until it gets a little bit colder. Then they get a little numbness or tingling and some other problem, and they say, yes, I've got to go in, I have a cold problem as well. Now, the Indian and Eskimo and Aleut, particularly those in the slope who worked in this country all their life, and they're hunting seal, and they're dipping their hand in the water and pulling out the whitefish and other things like that, they go right along with the individual, many of them, with no complaints at all. But they all freeze at the same time. So in going over some of our results that we had in the last 15 or 20 years, we found that some of the native people never realized they'd frozen their feet until they took off their boots when they got home, or took somewhere where they suddenly realized they had a problem. So it raises the question of whether acclimatization is something that's valuable or not. Well, what happens when you have this loss of temperature and cooling of the blood is if that cool blood goes up to the brain, if you wish, it goes to an organ called the hypothalamus, and the hypothalamus takes this, it's a computer, if you wish, for us in this particular regard. It separates all this information, and it says, hey, I'm getting cold, and it sends a message to the pituitary also, and it picks up one other little bit of information. I'll show you what we have here. Here's this wiring diagram that demonstrates all the areas where information is coming from, going up to the two shaded areas, the hypothalamus and the pituitary. And it says, by the way, because you had all that vasoconstriction and we have cut down the circulation to the hands and the feet and other areas, we're pushing all of that blood into other parts of the body. So some of those are third space parts, and they get shunted, if you wish, to the abdomen and to the chest and some other parts of the body. And those parts then start complaining and say, hey, I'm flooding down here. I have too much water, and something has to be done about it. And so the message goes to the hypothalamus. It goes to the pituitary. It then says, I'm going to shut off your antidiuretic hormone, and now you start urinating. And this is why you go out in the cold or come in and from the cold into a warm area, and immediately you want to go to the bathroom and urinate. So what you're doing out there is you already have very little water because perhaps you haven't melted enough snow to make it. You have very little water because this machine you are, like any other machine, needs water for metabolism to keep you warm and keep all of your organs functioning. And on top of that, you get a message, garbage in, garbage out, because you shunted the fluid from the outside to the inside that says, hey, I'm flooding, so you lose more fluid. And the result is, again, total dehydration and hypovolemia. So you're an EMT and you're out in the field. You've got somebody who's hypothermic, whether they're comatose, semi-comatose, or just possibly alert enough to give you some information. You can bet, no matter what else, without hardly ever losing, that the first thing they are is totally dehydrated. And there are other ways now we have of measuring that. But that's one important thing. You're going to give them fluids. We'll talk about that later. If you're in the position to give them fluids, because of the changes you have in electrolytes, give them fluids like glucose and sodium chloride if you have to, but stay away from anything that has lactate ringers and potassium. Well, onward. Accidental hypothermia, And this is something you should know too. I've been on a lot of maneuvers and been on a lot of these mountain trips and been with the military over many years. And I've hardly ever seen a time that some of the people who are the, if you wish, in your position or my position, that some of the men who are treating the patients who have the problem also, if they're out, may have the problem themselves. And I'm interested in this because hardly anyone who falls into this trap ever has an awareness themselves of what exactly is going on. So if you have someone with accidental hypothermia, the signs are shivering first, and before you have shivering, you can tell exactly when you're beginning to lose heat because you'll have goose pimples. The goose pimples are merely the erector pili that raise up the little hairs that are in the hair follicles, and they give you that protective layer of hair. And then you know that there's goose pimples when you come out of a cold shower or jump into a cold lake from a sauna. That's your first sign. Heat is being lost. Shivering, heat is being lost. Now, you can't count on shivering being something that everybody does at the proper rate. Some people shiver between anything under 98.6. They shiver at 98 or 97.5, and they'll shiver down to 95. Some people will shiver right up or down to 85 degrees, and we have record people who are being rewarned to begin their shivering at 78 to 80 degrees. And children will violate all those rules, and the best rule of thumb you have then for this, if you have it, is a low-reading thermometer to determine exactly what's going on with your patient. Well, these people have fatigue and deep cold, discoordination, they stumble, and then you come to the real clue, which is hardly ever violated, and it's a real good sign for you. At 94 degrees, most people begin to talk as if they have a mouthful of mush. And if you have someone who's on the radio and you think that he's drunk when he's talking to you and he's in a rescue situation or somewhere in the mountain, you know him well, the chances are he isn't drunk at all, but he has dysarthria, inability to articulate because of the loss of heat that he's already sustained. They begin to become disoriented, then decreased visual acuity. They go into semi-coma and coma, and most people figure that 88 to 90 degrees was a coma or a semi-coma. And we've picked people off of the shelf of a cliff in the Kodiak area and up in these other areas where at 80 degrees they're talking to you. Children may be 78 to 80 to 82 degrees. They recognize their parents, and they'll carry on a conversation, and therefore they're not totally examined. A rectal thermometer isn't used because someone will say, hey, they're all right, they're probably not hypothermic, they're talking to her. That doesn't mean a thing. Everybody is variable, and the only way you get the information you need is to have that low-reading thermometer if you're suspecting hypothermia. And on top of that, there are many other complications as well. Now, there's a lot of misinformation, as we're finding out, as you probably already know, some of you from practical experience, about hypothermia and other forms of cold. I like to term the fact that when they go into a coma, they're in a metabolic icebox. These are individuals who have sunk down to the level of 80, 75, going down to 70. They have hardly any need or requirement for oxygen. They go anaerobic just as well as aerobic at that time. And when you examine them, if you put a stethoscope on them, and many of you will, and you'll say there's no sign of a heartbeat or a pulse, no signs of life, pupils don't react. Well, you don't know that unless you put that stethoscope on there for 3 or 4 minutes. And you don't know that unless you have an EKG apparatus strapped on them and you take a recording every 3 or 4 minutes or 2 or 3 minutes, because we've seen them come in where they go along, and pardon any internists that happen to be here, they go for 2 or 3 minutes and then there's a little squiggle and a blip and there is some sign of life, and they'll go on like that. And if you listen for 3 minutes, you may find just a little something that represents a breath sound or a heart sound. So these are really down in the metabolic icebox, and because they went down so slowly, their metabolic needs are not that of the normothermic. And this is something I'm going to tell you now. We'll probably get a lot of argument. You have your opinion, I have mine. It has to do with CPR. The one thing I want you to know before we get too involved, and right now we have a lot of experimentation going on with dogs and sheep to answer some of these questions that are so troublesome. And there is a lot of revision now of the methods of CPR, as you know. But this much you have to know about the people that are down in their low metabolic icebox, and that is that when you use CPR in a patient who's presumably totally comatose, you can light off from someone who has a relatively normal but a very abnormal or slowed rhythm, a ventricular fibrillation. And if you get someone in the field in the rescue situation with ventricular fibrillation, you may not be able to control that. And there's reason to believe that an abnormal or a ventricular fibrillation is not better than any fibrillation at all, because you don't know whether, with the tools you have out in the field, whether they have any fibrillation at all or not. But these people can stay in a metabolic icebox for a considerable length of time. Now, the reason we know this is that we've brought them up in a rescue situation by radio where they're down and have no signs of life and there's no other help available, and they'll come right along until slowly there's a very obvious bradycardia with a great space between the time. Then they go into something that looks like a atrial fibrillation perhaps, and then go into a normal sinus rhythm. But whatever you do, you don't want to precipitate these problems and make everything worse. It's said that they go into a cardiovascular death and fibrillate just before they die. This has been written up many, many times. There is no evidence anywhere at the present time in a rescue situation of what kind of death anyone really has when they die of exposure. We presume instead that they just have a total asystole and heart stoppage, and that's that. But these are things that we're now trying to work out in the laboratory. Well, if you can read this, it just shows you some of the interesting things that we've found here. And you can see on the left-hand side in centigrade and Fahrenheit what some of the low factors are. We've had people who are under 75 degrees, who are cold, they're blue, they're crying, they're awake, they're confused, they have hand motion, they have children who are uttering noises, they open their mouth although they're unable to talk. One was standing in the snow, as you can see. And you have to just revise all these things you've been taught at this temperature, this happens. That's nothing any more true in that anything can happen at various temperatures. Now, when you have a patient with accidental hypothermia, but for your information, this is what you really have to know. He's a cold patient, and he's in a metabolic icebox, and he's protected. He's better off if you have nothing to offer him in that metabolic icebox than warming him where you then have immediate demands to care for him, and there's nothing you can do about it. The purpose then is to bring this victim to a physiological responsive state, and that's under total homothermic control, his own control. Now, the thing you have to remember, particularly if you can't transport the patient for some reason, the whole burden of care falls on you, is that the higher the temperatures of your thawing method, the less time you have to direct and control and maintain this normal physiological state of pure hydration, the proper electrolytes, good acidosis, or rather good blood pH, and everything else that's necessary for a normal patient to respond well. So you rewarm only when you have total control. And in summary, if you're in a situation where you have nothing much else to offer, then the way you rewarm so you have total control and can handle a situation is very, very slowly and gradually, almost letting the patient respond. You do that by adding a little heat and making sure that he himself doesn't lose heat. Now, it's something I wanted to tell you about CPR, which is something to think about. And that is because it's been a big problem and puzzle for many of us in handling these patients, is that all the rules for CPR, which have done so much to preserve life in so many different situations, were written for the normothermic heart. And we suddenly realize that we know very little about the hypothermic heart, and that's why some of this controversy has come along. Everything that is true for the normothermic heart is not necessarily true for the cold heart. Well, we're doing a lot of work on McKinley, as many of you from the Talkeetna area and elsewhere know. And we've had research stations up there for 3 years now, and we're putting all of our material in a computer, and we hope that we've come up with some methods that will help in rescue and help in diagnosis and care. And this is a bioimpedance plethysmography unit. Over the plethysmograph is in the lower left-hand corner. It measures in ohms the current at different levels of ankle and different levels of wrist, if you wish. And from that, we interpret the amount of total body water, regional water in the head or chest at the present time, and fatness and leanness and other interesting problems that are of some concern to us. And it has its own physiological data bank as well as a printout over in the left-hand corner upper, and as well as an area where we infuse the questions and the information that we request from this. So we hope to have some more information and use in the field. Well, when you're again out in the field and you assess the patient you've picked up, you may be able to find, is he truly in a position where, first of all, has he lost lots of water, and is that going to be one of my criteria? This patient warms and I take care of him, particularly with hypothermia or severe frostbite. And you lose the water, as you know, from tears, and if you've had an NG tube in there, the chances are good you not only sucked out some fluids, increased as dehydration if you didn't replace it, but certainly sucked out hydrogen ion, and you convert the acidosis they're probably in into alkalosis. And if you go on treating them with for acidosis, then they'll die of severe alkalosis, which is also interesting. You can lose fluid from vomiting and bleeding. Most people aren't aware of that, but you lose 2 or 3 units of blood, and you've lost 2 or 3 units of fluid as well. From sweating, from burns, frostbite, metabolic needs, from urine, and from evacuation of bowel, diarrhea. And up in the mountain, if you have this kind of a problem, it's something to remember. That's a big source of water loss as well. Well, besides all the other problems, we've just had a very interesting series. We had 3 cases, mountain rescues, 1 airplane crash, and 2 mountain casualties, 3 patients, and they all had hypothermia, and they all had something else very interesting. They all had fractures of the 1st or 2nd cervical vertebral body. And those people who rescued those men really deserve a bouquet of roses doubled, because they did just a fabulous job. And one of the men was on Mount Marcus Baker, who fell 1,000 feet, and in the process he had a severe fracture of his cervical spine. In fact, he fractured the odontoid and shoved it forward about 50% in flexion. Now, if that had been an extension, that would have been the hangman's fracture, and that would have been the end of that. But his colleagues who also fell put him up in a proper position, kept him in a warm sleeping bag, put food and water nearby, although I understand some of the water froze soon. But they took such good care of him that he didn't freeze. He had cold immersion, had immersion injury or wet cold injury, I would think, to his feet, and had a few other minor changes and was dehydrated and slightly hypovolemic. But his companions who went out for the rescue and were able to walk out did have severe freezing injured extremities. So just by what little they did, they not only took care of his problem, but they prevented the cold injury. And we'll discuss some of that a little bit later. One of the major problems that you see right there is the fact that these people, besides being mountain climbers and dehydrated and having many other problems, have the following problem. These are the Japanese climbers who nothing phases them. The Koreans are much the same. Some other people are very much like that. But these people particularly give us a great deal of trouble on Mount McKinley. And they're unstoppable. The man in the front has high altitude cerebral edema. The man behind him has pulmonary edema and frostbite and is about to fall. And the man behind him has pulmonary edema and frostbite, and they're dragging him up to the summit because they don't want to stop. Well, when you have someone with severe hypothermia, and particularly on the mountain, it's just not hypothermia, because you have many other problems that precipitate something like this. And complicating the hypothermia and the cold injury we have now are the use of recreational drugs. And if your patient is comatose or semi-comatose, sometimes you can't tell whether this is present. And if you really suspect this, and we're doing this in the emergency room, and I don't know what you're to do if you're out in the field for any length of time, you probably wouldn't have the Narcan anyway, but we're giving Narcan to wipe out any of the drugs that are aboard to give us a hand in the diagnosis. Well, this man, besides his cerebral edema and his frostbite, had a head injury, closed head injury, was treated on Mount McKinley. He and another companion had fell many hundreds of feet, and both survived because of the emergency care that was given. It's the kind of care that you'll be able to give, even though there were doctors present. The tools were no more better in their hands than the ones that you'll have in your vehicle or in your rescue wagon or on your back if you walk in for them. Again, the chopper for the evacuation of patients. Beware of the chopper itself, that it doesn't contribute more to the cold injury than was already present. Now, the problem again is that your patient, if you know that he has hypothermia, has a lowered core temperature. His metabolic system has a decreasing function, which is not too good for him, but in a cold situation is happy perhaps. He has severe dehydration and loss of caloric reserve in many cases, unless it's an immediate fall in a lake when he's rescued right away, so that he's going to need food, protein as well. He has certainly enzyme system dysfunction, and you hear a great deal about pancreatitis and other diseases like that, and we've measured this, and one patient was even operated. I've never seen a patient with hypothermia with pancreatitis. What they really have is an increase in their amylase, or those enzymes, and that comes about because of the changes that occur in the enzyme system due or secondary to severe cold. There's hypoxia of tissue, metabolic acidosis, and renal dysfunction, and also increasing loss of neuroregulation. This is more prevalent in children than it is in adults, and tremendous fluid shifts and electrolyte imbalance. And this also is a trap for you. You don't have to worry about that because you don't have any way in the field of measuring a pH in most cases and the electrolytes, but you can make some assumptions. And one assumption you can make right off the cuff is that your patient is dehydrated, he's acidotic, he probably has an increase of potassium that's into the system and is circulating in the system, and if it strikes the heart, is liable to cause a hyperkalemic heart block, just as you have in surgery. And that's when you particularly have hyperkalemia or increased potassium, when there's severe frostbite of both or all four extremities, releasing from the damaged tissue the potassium that was in the cells and then gets into the serum and the circulation. When this all occurs, of course, and all comes to fruition, you're in the metabolic icebox, and then they're safe for a while unless they keep on losing their core temperature. Now in the field, if nothing is done and they aren't found, then they'll eventually be signed out as a death from total system cessation and exposure. But after rescue, then life is dependent upon the orderly reorganization of the organ systems and dependent upon you. And it's very, very interesting to many of us that people die of exposure, maybe 2 or 3 or 4 times die of exposure in the state of Alaska, never get to a hospital, and they're found in the spring or some other time. But more people die in the hospital than they die during the period of rescue. And this is something that we have to really think about and see what we can do to overcome that. What you're attempting to do is, under control, you want to rewarm this cool body and elevate the core temperature. Now, in your particular case, before you get to the hospital, and we're not going to discuss hospital care, well, first of all, you want to make sure there's an adequate airway. Mouth-to-mouth resuscitation sometimes will even demand that. You need an airway to get oxygen to the lungs. And if you use mouth-to-mouth resuscitation, you have warm air. If you're not going to use mouth-to-mouth resuscitation, you want warm, moist, inspired air oxygen if you happen to have it. Now, all the rest of this, the correction, the restoration of fluid electrolyte imbalance is not a problem for you unless you happen to have the patient that you can't get him to further care, to tertiary care. You can, when they're able to swallow and demonstrate that they can breathe well, correct the dehydration by giving them fluids. The acidosis would be, your alkalosis is a total guess, but you don't have much of a problem if the patient gradually warms up to the point where he's responsive. Then the body will correct all the imbalances that occur, providing there hasn't been a great deal of blood loss and providing there is no other associated complication or injury. The restoration of the renal function is dependent upon the use sometimes of Lasix or Motrin or some other drug. And some of you, I'm not sure whether EMT3s have that in your truck or not, but by radio you can discuss this with a physician and decide whether or not it's important to use. I think anyone who has hypothermia and has severe damage, particularly with associated frostbite or injury, certainly is deserving of having something that will increase the renal function. If you're in the field and you have access, it's helpful to develop multiple intravenous access. Even if you have to, and can do it no other way, reach in there and drop a needle into the large femoral vein or artery, anything to get fluid in if the fluid is available and your patient isn't doing well. We'll discuss that, and it may not be within your area particularly. Now, you can monitor the heart and the vital signs, the fluid intake and output, by any manner of means that you can. And we find that that is something that is probably cavalierly treated, but you'll know now that just about half the time when I'm told that the patient is comatose, there are no vital signs, he's in profound hypothermia and near death, the chances are if you'd sit down and really work at it, or had a Doppler, had other means of measuring, or you left your EKG strip on, or you listen to your stethoscope for any great length of time, you may find that the patient isn't as bad as you think. Now, we have a lot of other interesting problems that come up, and one of the problems is, when is your patient dead? Now, I can tell you this much, because if you may not have a thermometer, even if you have a thermometer, if you had, this is an individual in Mount McKinley, if somebody is brought to you or you see someone in the field, and you know the ambient temperature, the temperature around you is 35 degrees Fahrenheit, and that body temperature is 35 degrees Fahrenheit, they're dead. If the patient's temperature at the area of 35 or 40 degrees Fahrenheit is up around 55 or 60, or 65 or 70, then you must assume that they're alive, and then you treat them until they're warm and dead and not cold and dead, because you don't know which way the temperature is really going. And so that is a big help, and it's just unfortunate, and I'll just tell you this now, that in the last several years, I know of several cases where the individual's been left somewhere in a survival situation by a rescue team because someone has said, well, he was talking to me 5 or 6 minutes ago, and then he suddenly fell over. I couldn't rouse him, and he was dead. And something else happened somewhere else, and they fell in a crevasse, and I worked on him for a while, and then they stopped talking, and he was unconscious, and I realized he was dead. After that situation here in the streets of Anchorage, we find people, and 12 hours after that happened, we bring them in, and you can resuscitate them. So you don't give up on them, ever. And you shouldn't ever say, just because everything went, that they're dead. They're certainly not. They're just in that little metabolic ice block. Well, we go on. This is what you see, a little squiggle, if you wish, which is an Osborn wave or J wave, and said to be pathognomonic of hypothermia. We've treated almost 100 patients with hypothermia, and less than 7 or 8 of them had that particular sign, so I don't pay any attention to that. What you do pay attention to, though, is the lower 2 strips where you see tremendous changes that may represent a ventricular fibrillation or a wild arrhythmia of some sort, and actually what it is just shivering. So take a good look, because somewhere in your line of shivering you may find the peaks of the QRS intervals, and put the light of that. CPR, we'll discuss that if you wish. Use it or not use it. Certainly the mouth-to-mouth resuscitation, some of the thoracic pumping is certainly fine, but you really get into a lot of trouble if you're in a situation where you don't have the other drug to help you, if you develop someone who has no arrhythmia into a very severe ventricular fibrillation. There's here, again, going back to Elisha, who CPR, you know, the American Medical Association took credit for that, but here several thousand years ago, Elijah did CPR on a child and resuscitated him, so everything again, and nothing new under the sun. And here I've already talked to you about that and showed you that red line. Be happy, be content. If your patient is 80 degrees or higher, the chances are good no matter what you do, you'll save him. I show you this because down in the lower corner here, if you see, is that in focus? Yes. Okay, well, we have something in Alaska I want to alert you to called a Disrobing Syndrome. We didn't discover it here. It was first brought out about in the Scandinavian literature a few years ago, and we went over some of our own cases and found that much more of this is present than is commonly suspected. A great number, 3 patients last year, as a matter of fact, towards the end of the year, were found in this particular situation. Somewhere in the process of losing heat and developing the hypothermia, probably between 90 and 88 to 87 degrees, because almost all these people are ambulatory walking or crawling. They develop an overwhelming flush, so far as we can tell, and they begin immediately to disrobe. This may be one last agonizing method of trying to restore heat. And in every case, the disrobing is usually, in every case I've seen so far, it involves the pants in the men and the skirts and the panties in the ladies. They lift up their skirts and drop their panties. They take off their shoes, take off their stockings. Always a lower extremity, at least to my present finding. And then they leave a trail as they go along, and you can almost follow them. Eventually, and some do it all in one spot. But the primary problem is whoever finds them sees this, and immediately the police particularly say sexual assault. So then they cauldron off the area, and for sometimes up to 1 or 2 or 3 or 4 hours, that individual may be there because they're victims of sexual assault and dead and no signs of life. What we want you to do when you come into that is tell the police, pass this on to your police people, tell them to get a can of red paint, paint the body in if they wish, but give you the body. It was that patient's hypothermia, because this is one of the cardinal signs, and take them in and see if you can resuscitate them. Many lives have been saved by doing this, and so we checked around the state and found that in almost, there were in something like 8 to 10% of the cases, and I think eventually that's what our case number was, something like 8 or 10% of everybody involved in a hypothermic exposure situation had that particular problem. Well, here we are on the mountain again. It's, as you have heard me say before, it's the greatest outdoor laboratory anybody ever had to work with, and people do things for me there they wouldn't do any other way to get us the information that we need. Now, here's a case that would delight any EMT. This man was a leader of a party. He fell down a mountain. He had a line attached around, attached to two other climbers. They were both killed in the fall, and he hung upside down for about 8 hours and had this line wrapped around his knee. He sustained a fracture dislocation of his knee. He froze his knee to a level of about froze his right leg to a level about 3 inches above the knee joint. And here you can see the dislocation. And when the arteriogram was done, you can see the femoral artery, popliteal artery, was totally occluded about 2 or 3 inches above the knee joint itself. Now, the interesting thing about this fellow was that he was rescued at 8 hours. He's brought into a snow cave, and there they warmed his hands, which went on to refreeze when he got into the helicopter. He lost some of his fingers. But they maintained ice packs and snow and ice on his leg because they thought the damage to whatever the injury was such that he'd do better cold. We got him and operated him at 36 hours. Now, in most cases, if you haven't operated a popliteal artery by 6 hours, you probably lose most of the leg, 80 or 90% of it for sure. And this man went on and lost just his toes, a segment of his toes, because he had been in this metabolic icebox too and had such cold care that he did very well. So you can make the cold work for you in a way that's advantageous. Well, if you have methods of thawing that you can use in the field, we have passive, use dry clothing, dry blankets, dry surfaces, place them in a tent, put them on snow cover. Most of you can do that. Dig a snow cave. This is better than nothing. It really isn't very good, I can assure you, if you live in this for any length of time. But it breaks the wind, and you can keep the temperatures at a fairly decent rate. You can get in a sleeping bag, have another warm body if you wish that try this. Some people like that, but if you're both in the same situation, two cold bodies don't warm each other very well. Now, there are active methods of warming that you can provide. We're not worried about the diathermy, but the warm body, the warm blankets, the campfire heat, the fireplace heat, Norwegian charcoal burner. This is good, but if you do this and you have it near someone who, besides a hypothermia, has frostbite, you may, by excessive heat, go ahead and cause further damage to the extremities. Here's a Norwegian body warmer. This we used on Mount McKinley. It did well at 7,300 feet. It did poorly above 10,000 feet. But this is a strip that has a D-cell, a charcoal segment that's set in that little stove. It's lit off by a match, and this thing burns beautifully. It has a little heater that works as well. It has a strip that's about 4 feet long, and for 8 to 12 hours will maintain a heat of 90 to 98 degrees. You can put that in the sleeping bag, and it's been used by the Norwegian Army, some understand with the Swiss Army now. It's really a fabulous piece of equipment if you're out alone and have someone in an Akio or someone that you're hauling along on a sled or trying to get them down from a mountain. There are other methods of warming that you can use in the field. Most of these are hospital. I don't recommend the warm enemas or the gastric lavage. That's just a lot of trouble. The mediastinal lavage you don't. But you'll notice down there at the bottom you have inhalation with warm, moist oxygen or and warm intravenous solution. And here you have the UVIC heat treat. Any other method of providing warm, moist air would be helpful as well. And once again, we want to say, if you're going to treat this individual in the field, if you use IV fluids, make sure they're at least 98, 90, 95, 105 to 110 if you can get it. There's no sense in having someone whose core temperature is 80 and then get the usual IV fluids we get in this hospital that are held somewhere in storage at 68 degrees and expect to be warming them when you're cooling them down. By the same token, if you're using oxygen or some other inhalant under pressure, and we have this in the people in surgery periodically get this sort of treatment, you have gas under pressure, and when that pressure is released, it cools, and under pressure it's heated. So now when we have someone who has warm or is given oxygen under pressure, and then you let that expand, they breathe it, we measure this, it goes down to about 65 degrees. So if you're giving oxygen to somebody who is in hypothermia, you're not going to accomplish very much in that way. So you have to really give some practical consideration to some of the tools you're using. I throw this just to show you that there are changes that are a little bit beyond you. Most of the patients on the left are in a state of acidosis. You can count on that. You can take it to the bank if you wish. Potassium is something else, but once you correct and warm the patient, the potassium tends to flow back into the cells and get out of the digestive system and cause you less trouble. There are other areas of cold like trench foot, immersion injury, and chilblains, and these occur at low temperatures but not near the freezing level. And the interesting thing is that they're more painful because of the damage to the nerve and the arteries than some of the cold injury with the frostbite, because once that's over, it's really over. As soon as you can get these people out of the situation, you want to put them in warm stockings and avoid the cold insult. And I've found that even after 8 hours of exposure in real cold water, if you're an immersion victim, you may have severe trench foot that's lasting for 6 or 8 months or longer. There are many ways of losing heat and many ways that develop stress and problems in the Arctic or in the cold. And you may have, besides your problem of hypothermia or frostbite, someone who has a tremendous psychic response and is very difficult to handle. In fact, some of this, the stress itself, may have resulted in the cold injury because of the overwhelming depression. Many of these people out in the cold also have a stress syndrome. They develop a curling ulcer. They have, they vomit blood, and they have a gastric full of blood, and that's also one of the problems you have to face, particularly if you can't get any help. Well, other forms of cold are cold urticaria, where you break out on a rash, cold hemoglobinuria, where you urinate blood or segments of blood and urinate protein, and headache and digital blanching. And this sort of thing is important, and we'll discuss that later. Now, just I have to tell you a little bit, because we see lots of these patients in the Bristol Bay and the Cordova, Prince William Sound, and the Kodiak area, falling in the water or having exposure problems if your vessel sinks really develops in a very rapid hurry hypothermia. We used to lose, we still do, we lose about a boat a week in the North Pacific, and we used to lose most of the crews. And now with the advent, and particularly with some of the new equipment of the survival suits, about 90% of the crews survive, and that's really great. And so occasionally now, instead of having, we have a little bit of hypothermia, but they usually do well. We have secondary changes as a result of immersion injury or cold injury or frostbite, but not as many deaths as we had before. And this is what you see if you have someone with an immersion foot with the crenated and wrinkled skin, insensitive skin, and the damage very often to the nerves and vessels. It's important. This is what the foot looks like eventually when they come to the hospital. It was like that when he was picked up in the raft. And it causes lots of other problems. What you want to do is make sure their feet, when you rescue them, aren't in the dependent position, because of what they really have is great big subfascial spaces filled with fluid and edema that will cut off the circulation. This is true on the mountain as well. Now we're getting down into frostbite, and I'll go through this rather rapidly, but the event, as you know, is that you just lose enough heat that ice forms and freezes, and it occurs in the deep structures in the tissue. And here you see, we don't know why this happens, but in the upper left-hand corner, a little globule of ice formed between the cells. That collects and freezes the water. It puts salts that were in that particular solution, then surround that piece of ice, and more of that salt concentration increases, sucks out more water from the cells, till eventually down the lower right-hand corner you have great big masses of ice between the cells, compressing the cells, and eventually, if that continues, causing damage, sucking protein-bound water out of the cells and causing considerable damage to the mitochondria and to the constituents of the cell itself. And that's very interesting, because if you destroy the mitochondria, for your information, we get into this problem of water again. One of the main jobs of the blood is to pick up oxygen from the lungs. It carries it to the cells. It crosses the cell membrane, and then the mitochondria extract the oxygen from the red cells through the membrane, and they form, as a result, water, and that's how your cells are hydrated. And without that, you have dehydration even down the lowest level. Well, this is just to show you the reasons for some of the care of frostbite in the field and rapid rewarming. In the lower left-hand corner, you see, after Merriman and his textbooks, ice that has occurred in liver cells, hepatic cells, and it's a rapid freezing and a rapid thawing. The ice crystals get no larger than that. In the mid-segment, by thawing at room temperature or other areas, before you get total thawing, you have ice that accumulates at first to that extent and compresses more cells. But in the lower right-hand corner, you see that the ice is formed, and the interesting thing is that this was an ice and snow technique, and this very, very delayed thawing. And so if your temperature of the tissues is minus 20 degrees centigrade, and now you thaw those tissues, It'll get down to minus 18 degrees centigrade as you're thawing slowly. Then it'll refreeze, thaw, refreeze, till you get down to where you're 0 degrees centigrade and plus, and then total thawing has occurred. And that constant thaw and rethaw cause increase of the amount of water and ice, or amount of the ice and crystals that form in the tissues, causes further dehydration and destruction. So we recommend, if you wish, rapid rewarming at the present time as best we know. Now, there are many kinds of freezing injury, like frostbite mixed injury, freeze-thaw, refreeze, which is a disaster, always a mountain injury. High-altitude hypoxia and freezing, likewise usually a disaster because of loss of oxygen in the tissues. Compartment compression and freezing, which results in loss of part unless you relieve that. And extremity fracture and freezing as well. Now, you could do something about this even though you don't get them to the hospital. You could, number one, you should never thaw anybody in the field if they're going to refreeze. If you thaw them and they freeze, and you thaw them and they refreeze, you can usually count, in most cases of severe freezing, at a loss at the level of the second freezing. So even if there's no way for you to provide that protection, keep them in the frozen state till you get them somewhere where you can protect the part. If you can do it on the mountain, you do it anywhere else, that's fine. Just make sure that they don't refreeze and develop these other problems. Hypoxia is a major problem if you have someone at 20,000 feet or 18,000 feet and you want to keep them out of a lot of trouble. And if you can safely do it, get them down to 7,300 or 5,000 or as low as you can, as rapidly as you can. Now, many cellular changes occur during freezing, and you've seen some: the ice crystal growth, formation, protein structure changes, pH changes, marked dehydration within the cells as well, loss of protein-bound water. And this is all interesting to us, too, because for years we talked about vascular phenomena and what happened to the arteries. Like everything else, had something happen to it, but the arteries remained either open or closed. Arteries freeze as well. And so if the arteries are frozen and they're destroyed, you don't have to worry about thrombosis. You don't have any blood supply to begin with. The other problem with frostbite continues, the cell membranes rupture. And when you have someone on Mount McKinley, for instance, and have real severe freezing, someone's lost his boots or an airplane accident, or someone up on the glacier and you're going to rescue them, if they've been up there long enough, 4 or 5 days, if they have total freezing 4 or 5 days, if they've thawed and frozen and thawed and frozen, sometimes the freezing and the damage is so great that no matter what you do, you're not going to reconstitute those tissues, and the amputation level is automatic. Well, after thawing occurs, and that's where all the cellular changes occur, then we have all the vascular changes with the veins being plugged up and the red cells pile back up into the circulation. You have tissue edema and anoxia and capillary and peripheral vessel collapse, and then you get this pattern of cyanosis and thrombosis and clotting, and eventually gangrene and separation of tissues automatically occurs. And I just showed this to you, not because you're going to delve into this more than just a little bit, but you can see in the upper right-hand corner an artery that's filled with clot, and this is someone who had a freeze-thaw refreeze injury. And if you have all of your arteries filled like that, then you have very poor capillary circulation and little opportunity for the part to survive. Now, we have some drugs, some that could even be given in the field. They're called thrombolytic enzymes or drugs. Streptokinase is one, orokinase is another, but we've had a lot of trouble with it because if you give it and the patient has a head injury or spine injury or injury anywhere else, it'll cause bleeding in that part, and you may have saved the foot to instead give someone a closed head injury or a subdural hematoma, epidural hematoma, or a paraplegia from the bleeding about the spinal canal. Go back here. This is our patient that you're going to see. He's rescued. If he's hypothermic, he has severe freezing, and then when you get this area and get his socks off, you recognize he has total freezing of his extremity, and when you continue, you see here is a totally, absolutely frozen foot. I'm going to give a lot of trouble. Now, you know a lot about that. There's cell destruction. If you thaw this person in the field, plus his hypothermia, you're going to load his system with destroyed muscle cell. You may have myoglobin. You may have kidney complications. If you're anywhere near somewhere where he can be helped soon, you either leave him in the frozen state or let him thaw spontaneously, but don't thaw him very rapidly where he might, one, refreeze, or two, put himself in a situation and you in a situation where you don't have the proper drugs to care for him. We have other problems. You can abort some of these in your area if you see it. This is a new method that mountain climbers like now. They have a single or double layer boot, leather, and then have a neoprene liner, usually with a scuba sock or with a zipper. And when you have this, neoprene has cells, and when you get up above 14,000 feet in Alaska, 14,500 for sure, higher than you would in around the equator, the Himalayas, you get a barometric pressure is about 1/2. And you have a tightly laced boot, so when the neoprene cells expand, that decreased barometric pressure, there's a great big expansion, and it can't go up against the boot because the boot doesn't give. So it goes down against the skin, which does give, and compresses the skin and the vessels underlying it. And here you see, many of you have seen this slide before, I think, a total absolute destruction of tissue. You don't have to have a freeze, thaw, refreeze, which this man did anyway, for the simple reason that he's had vascular occlusion and a tourniquet, which we don't like to leave tourniquets on for over 20 minutes. In most cases, you like compresses and don't like tourniquets, and this was on for something like 5 days. So the result is a total disaster. These are the hands that had thaw, freeze, thaw, and this man further complicated his problem by not having water for about 5 days. I show you this because this is similar to what you just saw in the field, and why you can be guided by what you're going to do and how many risks you're going to take with a patient. This man was in a blizzard 4 days. He had boots. He froze and thawed. We got him in and did a fasciotomy immediately, and this is just like doing an autopsy in a morgue. You can see there's absolutely no blood supply to that foot at all. This is a very common finding, and it precipitates the frostbite, and something you can do about it when you see it on the slope or you're taking care of people with painful hands. This I call a labile vasomotor pattern. This is found in women, something like 90% compared to 10% for men. They're the ladies with the warm hearts, I guess, but cold hands and cold feet. And they sit over the edge of a table. They're a little bit cyanotic in a dependent position. If they have a hand that has normal texture and the temperature outside is 60, and they hold their hand up and it drops to, say, 58 or 57, just that little drop with a little wind, and their hands will blanch. And this is one who responds now to biofeedback. So we have lots of people out in the cold. If you know of any with migraine or with this particular problem, biofeedback training will convert this cold hand into a warm hand. You have to know about a lot of other things. You know, you've heard us say over the past, we don't worry too much. You've seen frostbite of the ear and frostbite of the nose that had a bad result. But the new system, the new cultural changes that have occurred allow us now to treat patients who use recreational drugs. And here's an individual who was hypothermic. His temperature was less than, it's probably less than 75, maybe down as low as 70. We didn't get him for a while, and he was still in a semi-coma. He had a nose that looked like this, and he had been accustomed to using cocaine out in the bush. And cocaine, as many of you know, not only causes shrinkage of the nasal membranes, but at the same time causes a vasoconstrictive effect, and we use it in surgery for doing submucous resections and other operative procedures. So he went ahead without any problem and froze his nose. He sloughed the epidermis. This man did respond, not to aloe vera, but to warm soaks, and went on to a pretty fair result. So you have lots of other complications that you have to know about. Here's a mountain climber in an avalanche, and the thing you have to know here is when someone is in an avalanche and has multiple other injuries and frostbite, this patient in the helicopter, in the transport, in the fishing vessel before he got to the hospital, in the hospital, had an NG tube, and during that time we went down and checked him out, and we should be in acidosis. He was treated for acidosis and given alkaline solutions, and got worse and worse and worse, and finally went into a coma, and we finally got a hold of a pH meter and measured his blood gases, and he didn't have acidosis because we'd sucked out all the hydrogen ion with the NG tube, and he had alkalosis instead. So these little things, we can complicate our own treatment without problem. This is a Maillard Myth. This man was on the mountain. If you're one of the rescue people, if you're taking photographs and wherever you are, this should really be outlawed. We've had an awful lot of trouble with it. This is only, usually see this pattern in 21 days. That's 5 days worth or 5 days after the initial exposure in the hospital. Absolute mummification, total gangrene as a result of this. You don't have to worry if this is your patient. Just wrap him up and protect him, because he's going to demarcate right at that particular part. Now, in order of effectiveness, if you're out in the field and you have to take care of the patient, you can't get in, the happiest way is treat them with rapid thawing in warm water, about 90 to 106 degrees, whirlpool tub, or whatever else you happen to have handy. Now, if you can't do that, plus or minus, some results are good and some aren't good, depending on the vascular state. There's spontaneous thawing, That occurs usually at room temperature, cabin heat, thawed in foot traveler rescue, and sometimes you get spontaneous thawing when you're bringing the patient in, depending on how you're carrying him. Sometimes a chopper, sometimes your wagon is warmer than you expect, and you get some particular thawing. The worst type of thawing are the following two: delayed thawing by ice and snow or cold water, and certainly friction massage, and then thawing by excessive heat. And excessive heat is anything over 115 to 120 degrees. But when you stand in a campfire heat or oven heat, yeah.
I'm a little bit confused here. One portion of the lecture you were saying rapid thawing, another portion you were saying slow thawing. Is there a rule of thumb for when?
Yeah, I'm not saying either. I said in order of effectiveness, I didn't even tell you. I just said he had been thawed. The best method of thawing at the moment is rapid rewarming in warm water. Okay, you don't always have that choice. The second best method that gives results, that some are good and some are not good, is room temperature warming, cabin heat, thawing in an automobile, thawing in a sleeping bag. We call this spontaneous thawing. For sure, to give you a bad result are ice and snow techniques, cold water, friction massage, and then thawing by excessive heat, because now you have burning on a part that is already frozen, and the result then is just as bad as a freeze-thaw, refreeze. Now, there are drugs that we use in frostbite that are considered to be helpful. You may not have them all in your armamentarium. You may have priscaline, vasodilating agents, plasma volume expanders, but like molecular weight dextran is usually hospital therapy. But guanethidine and reserpine are hospital therapy. Nifedipine is also a hospital therapy. Sympatholytic agents like dibenzoline is a little red pill that is an alpha blocker, and you can carry that in your drug kit, and that is helpful. Heparin you don't have. Now, we may someday ask you in the early days to use thrombolytic enzymes if we can be sure there's no other injury, because that'll stop immediate clotting. And dimethyl sulfoxide may have, DMSO may have some of the very best methods in a situation where if you're an EMT for cold injury. The vets swear by it for dogs, but we don't happen to have permission in this state and many other states from FDA to utilize this drug, although we're working on it on experimental animals. If you can drop that slide down just a little bit, I just want to show you that whatever else you do, this is important to protect your patient who's a child. One of the organs most susceptible to cold is cartilage and growth materials in the child. Here's a young man who had frostbite at an early age, and the exposure needs to be only 15 or 20 or 30 seconds at 20 or 30 below zero, or even 0 degrees Fahrenheit, and you can see the changes that have occurred in the distal tip. And this is the x-ray. Did we miss one here? Okay, I guess we missed one. Anyway, the x-rays show punctate destructive changes in bone that are permanent, and usually you have almost total destruction in a child that's under the age of 3, so that you may lose all the carpi, all of the growth plates, and have a very small hand, and that's not uncommon for us to find in examining adults who have come in for, been referred from other cause and have very definite evidence of freezing injury. If you're out in the field and someone has a fracture, in almost every case you'll lose the part. If, one, you don't thaw rapidly in warm water, and two, if you don't splint the part so there's failure so that you have adequate immobilization and not motion, and three, if you don't elevate the part or do something else that's available to you in the field so that you don't have a compression syndrome, and certainly you don't want to use a tourniquet, and you don't develop so much swelling that the blood supply from the fracture alone is cut off. And that's your problem in taking care of these in the field. If they have a fracture, then there is so much surrounding swelling and edema and accumulation of fluids that you may cut off the circulation sufficiently such that they'll be susceptible to cold. And this is a result if you warm with warm water, even if there's a compound fracture, warm with warm water, put in a splint, and take care of the part until they can get some area where they can be treated beyond that. If you cannot safely warm them, then keep them in a splint in the frozen state and try to get them out as soon as possible. Well, I've got a little picture here that says we all make mistakes. You're not going to treat many cases of hypothermia and travel and moving around if you don't get yourself involved in a few mistakes, and particularly in the matter of travel and helicopters and handling the patient. And you have a lot of interesting things in the literature, and perhaps you've been taught this in some of your classes. One I think that's most interesting to me says that by many who are internists and cardiologists treating this, and many orthopedic surgeons as well, say whatever you do when you pick up the patient who's hypothermic or has severe freezing injury, don't rattle them, don't shock them, handle them carefully, don't put them in Occhio, don't bump them over the moguls, don't drop them. When you get in the helicopter, don't let the wind bounce you around. Don't hit the truck, have the truck run over the ruts. Don't do this, don't do that. If you do that, you get ventricular fibrillation, and you do sometimes. But then you go to where there's a good EMT3 and a paramedic and an industrial nurse and a physician, and you say there's no signs of life. And so what you do is you either put on a thumper, or you go and you break 7 or 8 ribs doing CPR, doing the same thing you've just said that you shouldn't do, because you'll get ventricular fibrillation, and you will. So there's a lot of little things here we have to consider and handle in the future and iron out. Lights, please. Before I ask you any questions, are any of you familiar with this? Is that all, just 4 or 5 of you? It's free. That's what it is. It's a book, The State of Alaska Hypothermia, Cold Water, Near Drowning Guidelines. Now, are you familiar with it? Okay, well, then, if you are, then I don't know whether you think it's complicated or not, but it gives some pretty good guidelines on what you can do in various situations to take care of people who have hypothermia, let alone frostbite. Are there any questions?
In our EMT course, Dave Decker suggested if you are using oxygen in the field, breathe it in yourself and then respire it into the patient before he takes it. You have a comment on that technique?
If the oxygen that he's breathing in is regular oxygen, not in a heater, I think that's a good idea. However, it's not coming out of him, with all due respect, as pure oxygen. A little bit of CO2 in there. But it's mouth to mouth. I guess it's better than no oxygen at all. But I can tell you that if you do not do that, or do something like it, and oxygen comes out, usually you might measure it for sun somewhere between 65 and 68 degrees.
What's a good field way of warming up as a standard oxygen supply?
Of doing what?
What's a good way of warming your oxygen supply out in the 40s?
I think having a heater, something like this UVic, or some method of having warm moisture. If you're in the business of emergency medical care, you probably should have something like a UVic heater. I would think if you have a truck that's heated, has a good heater, and you can keep the temperature of the truck something like, what, somewhere 80, or have a, you know, what I've done now is, I've been trying to get the military for years to do something, is I've designed a couple of things where you hook on to your exhaust. You know, nothing is more distracting to me than to have military vehicles by the hundreds go to a big maneuver like Polar Strike, where there are 12,000 men. They burn anywhere from 10 to 500 gallons of gas a day, depending on the kind of a vehicle or engine or airplane or whatever they are, and all of that exhaust goes out in the air. And all you need to do is run one of those exhaust pipes around a vat or a bunker or something filled with snow, or a barrel, and whenever you got where you're going, you'd have cold water. You could do that with an empty carton, and in it you could put your oxygen, you could put your food, you could put your shaving water, anything you wanted. You'd have water, you'd have coffee, whenever you got where you're going, and you wouldn't have wasted all those calories. And you can do that probably in your emergency vehicles. Yep.
What do you have to say about the special hypothermia cocoons that they're using, like out in the North Sea, and also these reflective unisuits that you can purchase?
I don't have very much to say because I've never seen either one of them. I have something to say in regard to some of the equipment that we're using in the fishing industry up here, and that is that if any of them are very much like the survival suit, in any similarity, they must really be doing an inadequate job, because I think the survival suit for the fishermen, we've rescued people at 5 days floating in a raft, another one 4.5 days floating in the North Pacific picked up off Yakataga, whose core temperature never dropped below 94 degrees. That's really impressive. It has been recommended locally here, and perhaps they had that in mind, that you use a crash suit, which you've used, you know, for severe bleeding and hemorrhage. And I don't know whether I would approve of that, because usually that means that the circulation to the lower extremity or some part of the extremities is occluded. I do know, let me tell you, whatever you use, that if in your situation, if you're anywhere more than 3 or 4 or 5 hours from rescue, many of you here are going to be able to transport to a major hospital in a hurry. But if you can't do that, you're better off to let the patient respond slowly to his situation and gradually warm, because he'll do that if you keep just adding enough heat. One, that he doesn't lose heat, and two, that you can restore heat. And he'll balance his own pH and his electrolytes in almost every situation, providing there hasn't been some other major problem that caused him to go down into hypothermia to begin with. And such a problem, for instance, we see not unusually is diabetic coma, insulin overdose, drug overdose, or something else like that. Yeah.
Assuming you're only an hour out from a good-sized hospital, should you try and rehydrate a moderately hypothermic patient?
I think I would have no objection to anybody adding water to a moderately hypothermic patient if you know that he can adequately swallow and breathe. Unless you're talking about IV fluids.
I was speaking more about IVs.
Okay. Well, if you're close to an area where you have hospital help, particularly since it's so difficult to start IVs in cold patients, unless you do a puncture, say, of the femoral system, I wouldn't think it'd be much of a problem. If you knew that you had a patient, though, who had been in the wilderness for quite a while, I'd do it. As a matter of fact, if you have normal saline, physiological saline, or 5% glucose in water, and you're an expert with a needle, you have a hypothermic victim, and they can't walk and can't talk, you know, can't help, I would say try to start an IV if you're that capable. It's essential. I'm sure it's needed. The question is just whether you can do it properly. The reason I say that is by do it properly is not that you would not do it, but now if you get it started in certain situations, you may find your bottle freezes or your tube freezes. For those of you who work in situations like that, there's a lot of equipment out now, particularly that the Norwegians and some of the Europeans have, and our military are developing as well, that will keep drugs from freezing, keep the IV fluids from freezing, and you know all the other tricks of putting a plastic bag in someone's axilla and keeping it warm. And that sounds good when you read it, till you realize that what you're taking care of is someone whose core temperature is already 70 degrees and they're cold, and their axilla is not going to keep that fluid very warm.
You're in the field and you have a small amount of equipment. What's the best way to rewarm a person?
Well, let's take the very worst thing. It could be you or a friend, and you're out and someone suddenly falls, is injured, is hypothermic, as say a snow machine went in a lake and you got him out, and then he's really cold. Suppose you're in the middle of the lake, you probably thought of that, right there in the ice, and you've got him out, and it's 4 miles to the beach. Well, you're in big trouble. I mean, but this happens, this sort of thing. You can do, you know, the book says take off his clothing and put something warm on him. You don't have that. So you can clasp him to your bosom if you wish. If you can, what you've got to do now is get off that cold lake and get somewhere where you can dig a hole and get him in the hole, and either share your clothing with him, get a fire started, or get into some kind of shelter. And so I think the first thing you have to do and consider, if possible, is he's cold and wet and dry him, or he's just cold and get something dry and warm on him. And then you have to get him into shelter. That may be the first thing you can do. And from there, you have to really improvise, and you have to develop fire if you can. If there's nobody else around to help you, and it's just you for 2 or 3 or 4 days, then you just have to do the very best you can with shelter first, warmth, and somehow think heat. You've got to generate enough heat to keep this fellow from losing more and gradually accumulating some. And this can be done pretty well if you're prepared and have some kind of a cave and are able to make fire. Then you're really out of trouble. If you very slowly warm most patients who are accidentally hypothermic, believe me, they'll recover of their own slowly. It may take them 24 hours, but they'll do it.
Yeah.
What is the usual amount of time for immersion foot or trench foot to develop? And what's best for that?
Well, I've seen it develop in 8 hours for people who were in the cold Atlantic or out here in the North Pacific of a certain amount. And the best field treatment is just to splint them, keep the foot warm, send them into the hospital, because their biggest problem early is severe pain due to the neurovascular stimulation that they get. We even the pain is so severe in the first 24 to 36 hours that we sometimes have to do an epidural block or a spinal for a day or 2 or 3 to get rid of the severe pain they have. And the other thing is they get lots of swelling and edema. And these are the people you have to operate over the artery and the nerve and do a fasciotomy. And their pain very often worsens over the months instead of getting better as it does in frostbite or burn or any other thermal problem.
Yeah.
With a hypothermic individual, when we deliver them to the hospital, what kind of report do you want as far as history and things like that?
Well, most important to me is what the temperature was when you found them, if you took it, if you could get it. And then what they were like, whether their pupils were dilated, whether you found any signs of life, and particularly what you did. You know, at this stage of the game, and there are probably lots of you say that you hear many varied methods of handling it. If you feel that from your learning, let me just tell you, we went 50 patients in this hospital without ever having any of them have CPR in the form of other than mouth-to-mouth resuscitation, warm, moist, respired air, but none of this cardiac massage and pumping. Now, if you feel, and you've been taught because you can read this, that you have to do total care, including compression of the thorax, and your patient, just look at the patients a minute. You're the ones who bring them in. If your patient comes in the hospital with ventricular fibrillation, you've delivered for yourself and for us a tough problem. Let me put it another way. Most of the patients we see with severe hypothermia usually are those who got it between 8 or 9 o'clock at night and were found 8 or 9 o'clock or 10 the next morning when someone made their rounds or the sun came up or light showed up and you found them laying there. They've been out 10 or 12 hours. They've been cold in that metabolic icebox for 10 or 12 hours. You, if you're nearby a lot of help, you don't have to do the whole world's work, including that total CPR and chest thumping and everything else, when you're only 5 or 10 or 15 minutes from a hospital. You know, it's really, it isn't right to set someone into ventricular fibrillation if you pick them up in 4th Avenue at 9 in the morning when they're usually found, or 8 in the morning when the cops go through the alleys or whatever, and they fell in there at 11 o'clock at night. You know, if you're going to do that, bring them to the hospital where they can get themselves wired up and monitored and the cut downs made and the blood gases taken where everybody knows everything about them, and then somebody can take the responsibility of doing whatever has to be done. If you can't have that, then you can, you know, do it the other way. I approve of you doing whatever you have to do if there's no other help available. Yeah.
Freezing situation, and since rapid thawing in water is the best method, say you're an hour and a half away from the hospital and you're in a warm ambulance. Is it best to cold pack them and keep them from thawing spontaneous until we can get them in here, or you know, should you, you know, really cool off the inside of the ambulance, or what do you think is
Well, you know, even if there was controversy in this regard, I can give you some answers. We've had enough people brought in various means to know what usually happens. People who have, if you have superficial frostbite down over the, say, the skin and some of the subcutaneous tissues, it really doesn't make much difference how you treat them. But if you have someone who's totally severely frozen, when you pick them up, someone like we had in Palmer who had been 14 days, freeze, thaw, refreeze, that sort of thing when he was picked up, that one you do no harm by keeping in an ambulance cold. But I don't think for your sake I would cool down the ambulance that much. I'd just keep him packed in ice packs and bring him in to be thawed in this area. I don't think it makes an awful lot of difference if you have superficial injury to your hand or your nose or your ear or your feet from something, as say on the ski slope. And the reason I know that is that about half the people we treat from Girdwood come and drive themselves home, and they put their feet on the clutch and the gas and they turn on the heater, and that's how they present in the emergency room.
And also, is hypothermia, is that such a life and death type situation? Say you're, really have a low core temperature, that maybe a medevac system would be a good way to get him in if you're, say, an hour, hour and a half out?
Hypothermia, if the patient is unresponsive, is a life-threatening situation, yes. And as soon as you can get them in, the better off everybody would be. But you also have this patient who has gone down, many cases slowly, in a metabolic icebox, and there isn't that hurry. And that brain is the same temperature as the patient, and it doesn't need all the help it would be if you had a normothermic brain and a normothermic heart.
How long can someone stay in this metabolic icebox condition before?
18 hours, as far as I know, is one of our records. I haven't really an idea, but I suspect that this one, I have an idea. It's very hard to document some of this because most of these people are picked up. We've had them anywhere from 12 hours, 8 to 12 hours is not unusual because that's what I think 4th Avenue is in some areas around here where they drop at night and they're picked up during the early morning hours sometime. I'll take perhaps 36 hours on Mount McKinley, and we don't know all that went on then too. It takes a while to get down and a while for the rescue and a while in the snow cave, but I would say probably 18 to 24 hours. You could go longer. We have one case that went to 65 degrees that lived, but all the others lower than 70 degrees died.
Now, when someone goes into this, gets down below that temperature, goes into the metabolic icebox, if their temperature drops no further, but rises no further, is that what you're talking about here? Being able to extend the length of time?
Yes, that's what I'm talking about. That's what I'm talking about for you. You don't want them to lose any more heat, but you don't want them to rise to 85 degrees where suddenly they need all of the electrolyte balance and the blood gas balance and everything else that's required and all the enzyme that may be required and the rest, reconstitution of blood or whatever else they're lacking, the need of setting their fractures and the oxygen that's required, all the rest of that, to suddenly strike you right there, and you're not prepared to handle that situation.
To take a situation you mentioned earlier this evening where you have a person that has frozen extremities, to pick them up in the field and transport and keeping those extremities cool, would it be useful to give them nebulized oxygen?
I wouldn't see any reason why you should. Is this someone with hypothermia as well? Just frostbite?
Let's say he has hypothermia.
At a warm temperature?
Keeping the temperature cool in the ambulance to keep the extremities.
Yeah, but I mean the oxygen he's inhaling is warm.
Warm, moist.
Yeah, I don't think that's a particular problem. It's been suggested that we're treating frostbite the wrong way, that instead of what we should be doing, instead of thawing him, and I'm sure there must be a better way of treating some of it. The problem we haven't yet faced or recognized is that some of the freezing injury is so severe that I'll bet you that 10 or 15% of all the patients we've seen over the year at this hospital had such extensive damage. We've proven that now with isotope studies and other studies that there was no possibility of reconstituting that particular patient when we saw him. He had total cellular destruction, which wasn't going to be recoverable. Now, along with this, then someone said, well, what you should be doing is not putting them in a warm tub and thawing them, but instead giving them warm intravenous fluids. But we've been doing that. That's what we've been doing for 10 or 15 years here. And we have warmed the cold individual with warm intravenous fluids, and we've given that to him, and it gets down to the barrier zone. But where you have total freezing, the vessels are frozen too. And so that fluid doesn't get through until you thaw that part. And it's only going to chip away a little bit with the IV fluids. We have to do it by some other method. I don't know if I hope there's better methods, and we're gradually adding little and little year after year to improve the treatment, like the aloe vera one of these days. Yes?
Can you please elaborate on the relationship between altitude, neoprene socks, and frostbite?
Well, it's not, it doesn't have to be neoprene. Let's go back again. For people who climb mountains in the Arctic or in Alaska or Canada, we have an atmospheric pressure change that's about 1/2 atmosphere at 14 or 15,000 feet. Now, in the Himalayas and in South America near the equator, this is supposed to be about level 17, 18,000 feet, so I'm told. Okay, now it's been very popular in recent years to take scuba socks or neoprene socks or some other cellular material for a sock, and you put it inside your climbing boot, particularly if you have technical climbs, and this isn't used with a vapor barrier boot. And then you lock these up so that when you're climbing, you have a solid boot, solid leather and the solid plastic. And the Koflatch boot, recent boot, has been this year, if our data is correct, and it looks like it's going to be, there was more freezing injury with the plastic boot and the Kinley than any other boot we've had, and they have a neoprene or some other type liner. Anyway, when you get to 14,000 feet and above, the neoprene, the cells in the neoprene expand because of the low barometric pressure. The pressure goes up against the solid boot, leather or plastic, and it won't give. So then it's directed backward as the expansion continues against the foot, where you have blood vessels and veins and arteries and nerves that are compressible, and the circulation is cut off and the tissues are compressed. Compartment syndrome develop. You have a tourniquet effect with no blood supply, and the result is usually a disaster. You saw the picture of 2 of those. That's very popular.
Sir, what is the extent of injuries that, permanent injuries that usually is sustained from a type of injury from contact, an injury from in a frostbite situation, where an individual gets frostbite from a contact with a cold object, metal or something? What is the extent of the permanent injuries that arrive from something like that?
Usually, if you can relieve the contact, there's hardly any, maybe a little scarring. I've seen certain segments of the tongue lost by somebody who thinks it's smart to tell someone else to touch their tongue to the railroad track out here. I saw the most dangerous of all, or the most obvious complication, is that the patient requires a skin graft, where when you finally do get the skin pulled away from the cold wall, it leaves a full or part thickness skin behind, and that's not uncommon at all. In fact, that's common in our areas down here where they have Tasty Freeze people work at night cleaning out the the tubs, and inadvertently will come up against the wall and forget to have turned off the machine. So, and someone will be stuck there until someone in the morning comes along and opens up the place and says, and finds the victim there plastered to the wall. But that happens periodically. Other questions? Yeah.
Yes, sir. Well, I think what I was more interested in was a situation where an individual would have, gotten some type of blips and everything from actually, not physically being stuck to an object, but just to contact at different intervals, and then, receive some sort of a frostbite injury where it did blip up and everything. What I'm interested is just, what would the extent of the permanent skin injuries be there on something like that?
You mean over a period of years?
Well, no,
months,
at
days?
a particular time,
I'm not sure I understand what you're talking about, but if you talk, for instance, of one of the commonest problems we have in Alaska in the military and out are people who are fuel handlers, and they use the same glove. And the glove is saturated with hydrocarbon over and over and over again, associated with cold and with wind and with wet and with evaporation. And those people get pernia or chilblains and very sore digits and ulcerating lesions and flattening of the pads and all sorts of other problems. And that's readily solved if anyone's in that situation by using adequate rubber gloves.
How do we obtain these free booklets that you're talking about?
I asked one of your mentors to bring some tonight. I don't know whether they did, but if you didn't, you go down to the emergency medical services here on K Street, and they're free.
People that have had hypothermia or frostbite, are they more susceptible to get it again?
Unless you're a drunk, you're not more likely to be susceptible to hypothermia. We have old friends that come in every winter who fall down in the street. And usually they do pretty well. But if they do that over 5 or 6 or 7 times, eventually the law of average gets them for the hypothermia. We have other people who unfortunately have disease states that contribute to hypothermia, and there are all sorts of those, including various forms of coma and dwarfism, metabolic changes that occur in some diseases, hypothyroidism, other things like that, and those people are usually alerted as to what their problem is, and they try to stay warm. But once you recover from hypothermia, you know, it's kind of interesting because normothermic individuals who sustain cardiac arrest very often may have brain damage. But I've never ever heard of or seen a hypothermic patient had brain damage unless it was associated with near drowning, which is something, it's a little different situation where then that can happen. But pure, straight, accidental hypothermia I've never seen. The individual with frostbite and immersion injury is at risk because often they lose totally the fat pad and the protective pads in the fingertips and the toe tips and have changes in the vessels and the nerves that contribute or make them more susceptible to injury. Okay. Thank you.